Think cervical traction is just glorified neck stretching? Think again. In this video, we're going to deep dive into neck traction, exploring the crazy variety of options, a practical guide to figuring out what to choose, and the big picture of where cervical traction fits into your effective physio treatment plan. And if you stay to the end, you'll get the most important precaution of all. You'll see that in the bonus round. But first, let's get an overview of cervical traction. Section 1, Cervical Traction Cheat Sheet Overview with a sprinkling of tips. What is traction? In the context of physiotherapy, traction is a treatment technique that applies a gentle pulling force to stretch or decompress parts of the body, typically the spine or joints, to relieve pain and improve mobility. So this traction is also called decompression therapy. So when you look at my cheat sheet overview of the types of traction, you see I've sliced this cake in a couple different ways. Cutting a cake into slices makes it easier to eat, right? Before we dive in, I need to talk about positioning and manual traction. I have two recommendations on positioning. My first tip for a treatment position is seating. We live in an upright position, so this is where you should treat your patients. Half the time, lying down relieves their symptoms, but we don't live lying down. We need to be functional. We need to be upright. Plus, a real-life patient comes with baggage, like gastric reflux or mobility issues or obesity. And it's just too difficult for them to be thrown around like a rag doll. We practiced these techniques at school or on different courses, and everyone was mobile and fit. Our fellow therapists could flip around this way and that, easy peasy, lemon squeezy. But in real life, patients are more like a sack of potatoes with arms and legs and a head on top. So my second tip is if you're laying down relieves your patient's symptoms, then they don't bother with traction. The treatment is just to have the patient lay down for relief. Progress to shorter and shorter times lying down. Don't overcomplicate things. Keep things simple. If lying down relieves symptoms, then lay down. So my next key takeaway here is to use manual traction to assess your patient's response to traction. I know this sounds obvious, but you'd be surprised how many times I've seen my coworkers just put people on the traction machine without testing them. Typically, this involves the Sperling compression test for cervical radiculopathy and the opposite, the cervical distraction test. My tip here is to not do the compression. Don't irritate your patients unnecessarily if you can help it. Just do the distraction test, which is basically traction anyways. If you know your patient will benefit from this traction treatment, then proceed. For ongoing treatment with traction, my first preference, yes, another tip here, is to teach the patient to do their own self-traction techniques, exercises. If this isn't an option or it isn't effective, then in-clinic machine-mediated mechanical traction is my backup. For manual traction, we have four main options on how you grab the head and some related insights. 1. Hold the patient's head like a football. Now let's make it more practical. My tip here is to use a towel between the patient's face and your chest. This ensures a comfortable and hygienic experience. Using a towel prevents the makeup smudges on your work shirt and maintains a professional boundary. Why bother? Well, we all have this patient. Or no towel, you choose. If you want to get cozy, it's up to you. 2, you can hold the sides of the head like in the seated distraction test. You just have to watch for earrings and hearing aids. 3, you can hold the suboccipital ridge. This is like the suboccipital release for headache treatment. This was popularized by John Upplinger and the craniosacral therapy craze of the 1970s and 80s. Unfortunately, craniosacral therapy isn't grounded in science, and they have some questionable techniques. It's one of those way out there wacky pseudoscience treatments that we should stay away from. So check out this video here. They talk about it, but I'm going off topic here. We're talking about using the suboccipital ridge for cervical traction. You can use your fingertips, but you risk irritating your little finger joints over the years. So my tip here is to use the entire index finger to support it by other fingers to minimize the stress through your little finger joints. Mulligan added a belt which lets you lean back so you're not just using your arm strength. Or you can have the entire hand cupping the suboccipitals with or without holding the forehead. I find this to be ineffective, so whatever floats your boat. 4, you can grab under the chin and the occiput. Some say this compresses the TMJ jaw joint, but I don't know if that's true or not. Also, holding the patient's mouth closed can make it hard for them to talk. So pro tip here is to show them the diver hand signals for okay, going up, or going down. Now we need an overview of your traction options. Remember this table? We'll go through these. For manual traction of the neck in sitting, you have two options. First, seated manual traction, like the seated distraction unloading neck test, you just pull up. You have to watch out for earrings and hearing aids. Second, seated manual traction, hold the head like a football, use a towel. Again, you just have to watch for earrings and hearing aids. For manual traction in supine, you have three options. First, supine manual traction, hold the sides of the head, like the seated distraction test. Again, watch for earrings and hearing aids. Second, supine manual traction. Remember the suboccipital ridge we talked about. Save your fingers using the entire index finger. We already talked about that. And I also recommend using the Mulligan belt, which lets you lean back and not just use your arm strength. The third supine manual traction is to use the chin occiput grip, and your patient gives you the hand signals as needed. For manual traction in prone, probably less common. Can you do manual traction in prone? I found this picture. You have your patient in prone on the table and use the face hole or the chin occiput hold on the patient with the head off the bed. Let me know if you do this. It seems pretty wild out there. Send me pictures. For all the neck traction devices used in the clinic or at home, there are various straps and harnesses to hold the head. There are two basic designs. One that uses the chin occiput. This is the standard way, and it's way more common, and they're everywhere. The other one leaves the chin free. These are less common. I've not seen these used much, but they are for sale. I've seen them for sale different places. Obviously, the strap harness needs to be comfortable for the patient. I don't have a preference. There is a case report of a unilateral facial paralysis after cervical traction. They don't say which harness that actually caused the paralysis, and they didn't say what type of harness was used. So kudos for them for getting their article published, but I don't know if this helped me with my clinical decision making. I don't have any great words of wisdom here, except that some people are really good at setting up neck traction and some people aren't. Usually when I work someplace new, I try to figure out who's got the most experience with that particular machine that they have and get them to set up all my neck traction patients. For mechanical neck traction in sitting, there's one design. You have a motor, you have a harness, you have a chair. These have been around in clinics for about the last 100 years or so. I love this picture from the 1950s. When was the last time you saw a physio wearing a tie? These devices are all pretty similar. You dial up the number of pounds, set for continuous or intermittent, set the timer, and you walk away. I'll talk about traction settings here in a few minutes, so hold your horses. The tip here is to give the patient the button to stop the traction machine if they need to. For the mechanical machine neck traction in supine, it's the very similar design. You got a motor, you have a harness, you have the bed. Some clinics have a traction machine, some don't. Essentially, these are all gadgets work the same way. You set the weight, you set continuous or intermittent, set a timer, let it do its thing. I know you're desperate to know what settings to use, but be patient, my young Padawan. Again, give the patient the button to stop the traction. For mechanical machine traction in prone, yeah, again, it's possible. I've never seen it done. I couldn't find any Google images. So why do I keep talking about this unused prone position? Because it comes up in the self-applied techniques, and I was trying to be complete. The last flavor of neck traction is patient self-applied. Some of these use devices that you buy. Others are home exercises that we teach to the patient. Again, I'm going to throw a bunch of these techniques out there for you. I'm sure somebody will comment about some whiz-bang technique that I forgot to mention, so let me know if I've missed anything. Like I said before, self-applied traction is my first choice to teach the patient. But first, here are some self-applied traction devices we'll talk about in the home exercises after that. The classic over-the-door traction, three basic options here. This is basically a harness and a pulley. The patient can be seated. This guy here is applying the tension with his hand. Some of these use a weight or a bag of water. The key here is that the patient is in control of how much tension they have. Instead of being seated, there are supine versions. The other variation is standing with a mini squat. This guy has a harness and a pulley, and as long as he can mini squat, he gets traction. It seems like quite the quads workout, but your patients may ask you about these. Beyond these, there are various harnesses and pulley mechanisms, but those are the basic categories I've seen. Soft inflatable collar traction. I recommend these to patients. They're cheap, they're comfortable, they're easy to use. The patient pumps it up like a blood pressure cuff. The patient is able to control how much tension and when to release. There's also a rigid version that I have not tried one, so I can't say whether it's better or worse. It looks like the same idea, but the soft collar has Velcro adjustment for size, and it's more like a big pillow. So buyer beware, right? Like the rigid collar traction device is a supine pneumatic device. This device is like the clinic machine, but with pressure going through the occiput. These came around out of the Saunders group in the 1990s. They tend to be expensive, and I'm not convinced that they're worth the investment. I have met very few people who have bought these, and nobody who has bought one was raving about how great they were. So again, buyer beware. An inversion traction table uses gravity. Usually we think about this for back pain patients, but the head will also feel gravity as well. So if you have an inversion table and you're comfortable being upside down, then you can try this for your neck traction. A rigid pivot at the occiput also uses gravity. This is the suboccipital release idea. Some people do this with two tennis balls taped together, and they put it at their occiput and lay on it. There are several different wedges and rolls that you can buy for this. This pivot has to be just the right size and in just the right spot to get that traction effect to work. Not too hard and not too soft. So it's kind of hit and miss. Alternatively, this can be done with the therapist's forearm as the fulcrum, so-called forearm traction. It's either a McKenzie or a Maitland technique. I don't know. If you know which one it is, let me know in the comments below. There are some home exercises we can teach patients. Some of these are hit and miss. They may or may not feel like anything for your patient. They may or not be tolerated by your patient. Some are more gentle and some are a little bit more aggressive. So go slow and stay in control. Here are several options for home exercises for self-applied neck traction. Chin tuck neck retraction home exercises. Straight out of McKenzie, right? Seated is more functional than supine. Is this traction? I think so. So start gentle. It's the best home exercise to start with. It's in every postural self-correction home program. Highly recommended. Remember my advice, don't make things worse, and no pain with exercise. Chin tuck with a gentle finger push. Self-traction by flexion and rotation of the neck. Stretch by pulling on your own occiput. Mulligan's neck retraction to extension using a belt. The patient is in control here. They go as far back as they feel comfortable. The hands stay up by the eye level. This is a great technique. Kneeling at the side of the bed. Your patient puts the elbows on the bed for leverage and then the hands on the occiput. Push up with the hands, sit back with the hips for that traction and effect. You can also do this with a belt instead of just your fingers. Or there's a variation where the patient cups his chin and gets a traction when he lets his hips go back. Be safe, go slow and controlled. There's Mulligan's fist traction. The patient puts his fist between the chin and the sternum, and that's the fulcrum. Then with the other hand, they reach over the top for the occiput and pulls the head forward for that traction and effect. Someone told me that they have achieved this with a rigid ball in between the chin and the sternum, but it never worked out for me. Let me know in the comments if you've ever used a ball for this. You have to be sure not to choke your patient, obviously. Lastly, we have hanging the head off the table. The patient lays down, shimmies so that their head is hanging off the edge of the bed. The weight of the head does the pulling, traction, and effect. This is difficult for real-life patients to get into and out of safely. So I don't recommend this. Not supine, not in prone. That's why it's not on my summary slide. What didn't we talk about is the angle of the head. Should it be a neutral, go into extension, go into flexion? It really comes down to patient preference. What reduces or centralizes the symptoms? Remember, don't make things worse. Neutral is the typical place to start, especially if your patient doesn't have a clear directional preference. The flexed position is supposed to open up the posterior facet joints, like with osteoarthritis. Extension is supposed to be a position that closes that posterior disc space, like with a disc radiculopathy. Now that we've covered how of cervical traction, let's tackle the when and why. What diagnosis and symptoms respond to traction, and what contraindications should make us think twice? Section 2, from diagnosis to action, neck traction indications, contraindications, and physio integration. The main indication for neck traction is neck pain or symptoms like pain, numbness, and tingling that go down to the hand. There's a bunch of different diagnosis terms that people use, like a pinched nerve, cervical radiculopathy, neck osteoarthritis. Some physios would put headaches in this, but there are many reasons for headaches, so I don't want to open up that can of worms today. The decision to use neck traction and the specific type employed would depend on the patient's individual assessment and diagnosis. There's a standard list of contraindications to neck traction all over the internet. I put this one together. So let's clarify this a little bit. Pregnancy or joint instability. Ligamentous laxity or joint instability risks further injury, especially second trimester to the completion of breastfeeding. Severe osteoporosis, compromised bone strength increases the risk of fracture. Spinal cord compression, conditions like tumors or a midline disc herniation can worsen with traction. Acute infections, such as osteomyelitis or other active infections. Neurological issues, conditions like myelopathy or acute torticollis. Recent significant injury or fracture don't make things worse. For example, no neck traction until more than 6 weeks after a car accident whiplash. Serious cardiovascular issues. Aortic aneurysms can worsen, blood pressure can rise, vessels can become damaged, vertebral-basilar insufficiency can become aggravated. Severe psychological issues may become triggered during treatment. Prior neck surgery, risk of aggravating the surgical site or hardware. Also, any vascular or otorhinolaryngology procedures, those are red flags for me. My tip here is, when in doubt, leave it out. Nobody needs neck traction. I know we're all eager to help patients, especially when they're in pain. But my other rule still applies. Don't make things worse. As you may know, one of my previous videos outlined my simplified approach to physiotherapy diagnosis and treatment. Remember that the 3 simplified diagnostic categories are overuse, traumatic, and systemic. 1. For an overuse diagnosis, neck pain or arm symptoms develop gradually due to repetitive strain or prolonged postures, often related to work or repeated activities. For patients with overuse neck pain, you may consider using cervical traction for pain relief. 1. After conservative treatments like relative rest and activity modification and heat have proven insufficient. And 2. The patient's pain relief is relieved by the distraction test. This should only be performed after a thorough assessment to rule out any of the other contraindications we talked about, and with the clear communication with the patient about the risks and benefits. Remember to start with gentle techniques, monitor the patient's response, and integrate traction with the other modalities like exercise and manual therapy for a comprehensive approach. Self-applied traction techniques would be best so that the patient can manage their own symptoms. 2. For traumatic diagnosis, neck pain or arm symptoms arise from a specific incident, like a fall, an accident, or a sudden forceful movement. For patients with a traumatic neck injury, the use of pain-relieving techniques like cervical traction should be approached cautiously, especially in the acute phase. My rule of thumb is not for 6 weeks after a car accident. A thorough assessment is crucial to rule out contraindications like fractures or instability before considering traction. Use the distraction test to see if symptoms are relieved before you consider using the traction as a treatment. Traction should be started with a gentle manual techniques and closely monitored for any increase in pain or neurological symptoms. Careful consideration of the pros and cons is crucial. Pain relief is typical, but a brief passing phase of this diagnostic category. The short use of neck traction can be considered, but integration into a broader recovery plan is most important. 3. For a systemic diagnosis, neck pain or arm symptoms are the result of the underlying medical condition that affects the cervical spine, like osteoarthritis or fibromyalgia. These tend to be gradual onset, chronic, throughout the body, and they're also managed but not cured with medications. When considering pain-relieving techniques like cervical traction for a patient with a systemic diagnosis, careful consideration of the underlying condition and its potential impact on the cervical spine is crucial. Remember the distraction test, if the traction is considered, it should only be implemented after a thorough assessment to rule out any of the other contraindications, and with a focus on gentle techniques and close monitoring for adverse reactions. Emphasize safe home use of self-applied traction for the patient to self-manage their symptoms. I've seen many patients just want to come into the clinic, get their neck traction, and do no home exercises, episode after episode of clinic passive treatment. Patients must be actively involved in their recovery. Patients must learn to manage their own symptoms. That is the active versus passive treatment argument I've discussed before. This brings us to treatment. Section 3, traction in treatment, neck traction as part of your comprehensive physio plan. Every comprehensive treatment plan for the neck pain or arm symptoms starts with a thorough assessment. We talked about that. We talked about the distraction test to determine if the neck traction is appropriate for your patient. Otherwise, the regular eval elements like range of motion, manual muscle testing are still useful. For neck patients, look at the shoulder, the elbow, the forearm, and the hands. You've got to make sure that you assess the hand function. In my video on measuring hand motion makes this easier. Also, my assessment tip here is to look at the gait. Observational gait analysis is another rabbit hole I don't want to go into today, but we must chart that the gait is normal, or if it's abnormal, is it ataxic? Is there a foot drop? My big concern here is cervical myelopathy. Chart what you see. If you didn't chart it, you didn't look at it, right? As I outlined in my previous video, my simplified treatment approach has 3 phases. First, pain management. Second is recovery of motion. And third, strength, balance, and mobility. Let's build on this framework. 1. Pain management phase. Most patients come to physio for pain relief. During this initial phase, our goal is to alleviate pain and discomfort. A pain-relieving technique like cervical traction might be considered when conservative measures such as relative rest, ice, and heat have not provided sufficient pain relief, and the patient's symptoms are relieved by the distraction test. It's essential to conduct a thorough assessment to rule out any other contraindications and obtain informed consent from the patient, ensuring that they understand the potential risks and benefits of cervical traction. Now let's dive into some specific strategies for this phase. 1. Patient education for posture self-correction. Try a cervical sleep roll in their pillow. Roll up a towel and slide it into the pillowcase. Another tip is to use a lumbar roll while sitting. This improves back and neck positioning. Also consider an interscapular roll between the shoulder blades if the shoulders are quite rounded. 2. The patient education for pain relief. Heat is an easy pain relief and relaxation modality. I use ice for the neck, sometimes post-operatively. Using a neck collar for pain relief is controversial because everyone is afraid of stiffness. But in the short term, the use of a soft support can really help with pain relief. It's important to wean the patient off soft collar support to prevent that dreaded stiffness that everyone seems to be so worried about. 3. Patient education for home exercises. We need some gentle, pain-free range of motion exercises to maintain mobility and minimize stiffness. Consider pain-free grip squeezes, Codman's circumduction cradled, dynamic hug stretch, dynamic arrest stretch. 4. Patient education for pain-relieving home exercises. Self-applied traction. We just talked about these. Chin tuck, neck retraction. Chin tuck with gentle finger push. Mulligan's neck retraction into extension using a belt. Mulligan's fist traction. This is also where we need to try the other McKenzie pain-relieving motions. Yes, I've already talked about the retraction and extension, but there's an entire system in the McKenzie world that they go into with their traffic light system to know when to stop and when to proceed. Plus, they talk about the lateral component. It's like when to add side bending for the arm symptoms. That's getting beyond our traction video here. But definitely look into the McKenzie system. The easiest way is through their patient-oriented books. 5. Encourage the patient to maintain functional activities at home as tolerated. Consider a walking program. 2. Recovery of motion phase. Beyond pain management, we focus on recovery of motion. Home stretching exercises are the best approach, empowering patients to regain control of their neck movement. I don't recommend neck traction as a means to improve motion. Instead, teach the patients how to move their own necks more effectively. If motion is lacking, we need to address this loss by starting with pain-free active range of motion, progressing to static pain-free stretches, ideally with heat. This self-directed approach allows patients to take control of their treatment and actively treat themselves. While neck traction isn't recommended for improving motion, self-applied neck traction can still be used for symptom relief as needed. There are other manual techniques to improve motion that are possible, but I prefer empowering patients to take charge. Put on your big boy pants and teach patients how to get themselves better. My tip here is to include some upper extremity neural flossing or gliding as part of their pain-free home exercise program. Nerve flossing or glides must be pain-free and gentle. This is one of the areas where physios disagree wildly on the exact specifics of the techniques. Do a Google image search or a YouTube search for median radial ulnar nerve floss, and you'll be amazed at the variety. Choose what makes sense to you. Remember, pain-free exercise and don't make things worse. 3. Strength, balance, and mobility. This phase, after the pain management and recovery of motion, it's time to focus on restoring function and independence. During this phase, our pain-relieving self-traction techniques take a back seat, and the active functional exercises become the primary focus. The goal is to restore strength, balance, and mobility, enabling the patient to perform their daily activities with ease. However, if a patient experiences a flare-up that limits their ability to participate, then a short course of traction might be considered to manage those pain symptoms. Allow for continued progress in the program. Start with some simple upper extremity strengthening, like start with grip squeezes and bicep curls, progress to bicep curls going to an overhead press, add closed kinetic chain countertop push-ups, especially if there are nerve signs like numbness and tingling and pain down to the hand. Beyond this, you need to consider the patient's functional needs. Are they lifting and carrying, or working at a desk, or driving, or meal prep? Encourage the patient to increase functional activities at home as tolerated. Tell the patient to use Physio as a resource to address what they are having difficulty achieving. So as you can see, cervical traction is part of the overall plan, and the patient must actively participate, not just get neck traction and leave. All right, now that we've got our patients moving and grooving with functional activities, it's time to address the elephant in the room, safety. Wowzers, you made it to the bonus round. Bonus section, safety first, how to avoid common mistakes and serious complications. I have 2 warnings here. First, don't make things worse. Second, there are rare catastrophic risks with the neck. First, don't make things worse. If you've seen any of my videos, you know how I emphasize pain-free exercises and gradually increase in activities as tolerated. It's crucial to monitor patients' responses to traction and modify the approach if pain or arm symptoms increase. McKenzie tells us that centralization is good and peripheralization of symptoms is bad. Pro tip here, if you're going to do manual therapy, be gentle, start light. How much pressure do you really need to apply? Obviously, you need to stop if it's hurting your patient, but that's the problem with quick adjustments or manipulations. They're over so quick, it's like an instant help or it's an instant hurt. It seems kind of risky to me. There are a couple of ortho docs on YouTube with reaction videos to chiropractors. Search for Ortho Reacts to Chiro. I can't watch them. Maybe you can watch them. I get the heebie-jeebies. YouTube and social media are also bad for some scary techniques. I've got to address a couple of these. This kid in a halo traction spinning around is for scoliosis. I've never seen this in real life. I don't know where it's done. Let me know if you use it at your facility. It looks totally tubular, but this isn't regular neck traction in your normal physio clinic. Similarly, there was this clip of guys doing neck traction exercises in a park. This is an example of untrained, unsupervised people taking serious risks of injury, paraplegia, or death. I remember I was telling you to be gentle and be in control. These guys look like they're out of control. Not recommended. There are also techniques where one guy does traction and the patient is braced or held. I'm skeptical that you need that much localized force. Again, not recommended. Second, there are some rare catastrophic risks with the neck. This is the worst case scenario. Usually in physio, we always talk about how we make our patients better, how wonderful our techniques are. But in reality, hot packs can burn our patient's skin. Exercises can make people sore. Your magic hands can injure patients. So less is more. When in doubt, leave it out. And don't make things worse. The common problem with neck traction is muscle soreness. So back off, less tension, rest for a few days, and it should resolve. Your patient can also get sprains and strains or worsening of neurological symptoms. So again, stop the treatment, rest, consider a soft collar. While uncommon, serious complications like spinal cord injuries or a stroke can occur with some neck treatments. Don't let anybody who isn't trained handle your neck. Even if somebody is trained, I'm skeptical. But that's my opinion. That's why I emphasize that the patient's self-applied traction techniques are the best. We teach patients how they should be in control of their exercises. One of the videos I came across was this one. As a physio, as a healthcare provider, you have to realize that there are risks with treatments that we do. The further we get away from the hospital and the emergency room, the more that we think we can do anything. That was those guys playing with the traction in the park. I've seen some things I wish I hadn't seen. But make your own decisions. So, can you use neck traction to effectively help your patients with neck pain or arm symptoms? Sure. So, can you effectively use neck traction in relieving neck pain and arm symptoms? Is it worth the risk? Well, for effectiveness, for acute neck pain, it's limited evidence. Try self-applied home exercise techniques. For chronic neck pain, there's moderate evidence. So, for short-term pain relief, again, try self-applied home traction techniques. For cervical radiculopathy, giving arm symptoms, there's moderate evidence for short-term improvement, so try self-applied home exercise techniques. But the other question is it worth the risks? The answer is, yeah, sometimes. Start gentle, monitor patient closely, and use neck traction in the context of all your other skills. All right, you've survived the theory. Congratulations. Now get to the fun part, making traction work for your patients. Buckle up, folks. Here we go. There's no magic protocol, but you got to start somewhere. Neck traction machines let you dial up the weight load somewhere between 5 pounds and 30 pounds. So start with 10 pounds and gradually increase 5 pounds depending on how the patient responds. Sometimes you go up 5 pounds, sometimes you go down 5 pounds. Listen to your patient. I've always used intermittent traction. It seems most comfortable for the patients and least likely to give side effects. Something like pull for 45 seconds and rest for 20 seconds. Part of the effectiveness of traction is the patient's ability to relax in the clinic, and so we usually put a hot pack on while they're getting the traction. Who do you think should get traction? Is it just the neck patients or just the patients with radiating symptoms? Let me know in the comments below. My 2 books are now available at Amazon. What They Don't Teach You About Documentation in Physiotherapy School, a short how-to manual for successful daily note templates, and From Injury to Recovery Through Exercise, simple functional exercise progressions for physiotherapists to restore lifting, standing, walking. Thank you for your support. Let's have fun watching this neat video together. And by subscribing, you'll be among the first to know when new exciting content arrives. Thank you.